So let me introduce our panel. There's Dr. Amanda Doyle, who will be speaking first in just a moment, Cathy Winfield, John Rouse, and Matthew Swindells. So let's begin with Dr. Amanda Doyle. Amanda.
Thank you. So quite often at this sort of thing, people want to know a lot of detail about governance, about the system, about the organisations. Don't want to talk about any of that, just want to say that the changes around how we make decisions and how we work together across organisations are really only there to put us in the best possible position to succeed at what we're trying to do. And so there's a sort of a temptation to spend a lot of your time and effort on that stuff, because in many ways it's relatively easier. But what we actually have to do is just as difficult, whether you're an accountable care system or whether you're a whole collection of separate organisations. One thing that is really important as you develop as a system is that you clearly establish what you're trying to do and what your common purpose is. So we've put some time in to be really clear that our common purpose about improving the health of our population, improving the clinical outcomes for our population, and doing it within the resources available is our single aim and objective for our whole system, moving further away from our individual organisations and what our responsibilities to deliver for that organisation are. But obviously the proof of the pudding is in the eating, and what are our patients seeing that is different. They are certainly seeing more services out of hospital. They're seeing less reliance on hospital services and therefore much more opportunity to get the care they want in their own homes, in primary care, in the community close to home. So we've moved on from being a vanguard to developing our extensive care service, which is about really intensive management at home and in the community of our very highest users. 50% of our resource was spent on 3% of our patients 2 years ago on the Far Coast. And we've made moves to intensively manage that 3% of the population in a different way, reducing reliance on hospital and freeing up resource to devote to the next cohort of the population. That next cohort is seeing what we call enhanced primary care. We have moved with all of our general practices into neighbourhoods, the sort of famous 30 to 50,000 population. Each of those neighbourhoods has a fully integrated out-of-hospital team, which includes community nursing and mental health and therapists and social care, working with practices with registered lists and actually putting a significant amount of resource into patients with complex problems, but perhaps not the highest users. We've invested in primary care, but a lot of the investment in primary care has gone into services that support primary care to deliver. So we've gone live with 7-day access for our population to routine pre-bookable primary care. We've integrated it with our urgent primary care service in our walk-in centres, urgent treatment centres. We have our GP out-of-hours services coordinating care plans, responding to paramedics who are in patients' homes. We've been able, through becoming an accountable care system, to bring our system together to deliver in the way most likely to achieve our objective. And in doing that, we are throwing out some of the perverse incentives in the system. So getting rid of some of that transactional relationship and actually devoting our energies into cost-effective pathways of care and actual delivery of care in a different way. It's not easy. Probably our biggest challenge is workforce. But as I said at the beginning, I think that this move is putting us in the best position we can be in at the moment to succeed.
Amanda, could I just pick up one point there? You know, there have been so many organisations, and as a GP, you've seen them as well, and people are resistant even outside the health service, not another pulling up the plant by the roots. Is that a problem? Does it involve any structural changes that people are resistant to, or can people within the profession immediately see the benefits that they can pass on in patient care?
different with different people. Clinicians generally immediately see the benefit and want to move very, very quickly, almost more quickly than we can keep up with. There's a lot of nervousness, particularly around the boards and governing bodies of statutory organisations who are concerned, genuinely concerned about the accountabilities they have for statutory organisations and the ask that we're putting out there for them to not forget about that, but not make that their primary concern. So what they want to know is, have I got air cover if I'm acting for the good of the population as a whole, rather than what I'm actually responsible for, which is the health of an organisation. And so we put a lot of work into trying to provide reassurance to help people think through those things. And there are people who don't want to change, and that is the same with any change. It takes time.
Cathy Winfield is Chief Officer of the Berkshire West Clinical Commissioning Group, an ex-nurse. Cathy, give us your perspective on this.
Okay, yes. I mean, I thought it might be helpful to pick a different example of where working as an ACS has been a practical solution to a problem that we faced. In our system, we seem to be doing pretty well. Our performance was pretty good. We were managing the money, but it's just not good enough. We're not going to be able to manage the demand we face within the resource we've got going forward. So there was an imperative for us to think differently and do something differently. So we had begun thinking about an accountable care system, probably for the last 2 years. We agreed formally to work together like that in June last year. And one of the examples that we've got in our patch, just thinking about the previous session, was that we were a significant outlier for musculoskeletal activity. So lots of hips and knees going on, lots of money being spent, quite short wait times, so the system running quite hot, and quite a big supply side with a range of providers, but our PROMS measures poor. So high spend, but not necessarily great outcomes, and a real question mark for us about where we're spending our money in the best place for our population. So we started to do something different and actually engage directly with patients and work with the third sector, with Arthritis UK, and we gave patients the opportunity to spend time thinking about their choices and what alternatives there might be to surgery. And we were absolutely astonished at the results of that. And after a relatively short intervention, 1 hour, 80% of our patients decided that they would manage their condition a different way. And we thought, well, that might just be a flash in the pan and they'll all rock along in 6 months' time. But we actually sustained that. That's been sustained over sort of a 24-month period. So it's not been a short-lived feature. So while it's absolutely right to put all the effort into improving efficiency on the supply side, on the provider side, it's equally important to go back to basics and engage the patient and fundamentally ask the question of, are we doing the right thing? And given that we also have quite a lot of private activity in Berkshire, an affluent leafy area, of course we don't count that in our data. So there must have been virtually nobody with their own hip or knee in Berkshire. So really, we did have to sort of think about it fundamentally differently. So we started saying to our provider colleagues, right, we want you to join in with this, and if you get referrals through and there's no evidence that a patient's been through shared decision making, had that opportunity, we'd like you to send the referrals back. And in fact, we're going to contractually ask you to do that so that we don't get anybody listed for surgery that hasn't had that opportunity. And that was really when the ACS way of thinking came in, because our colleagues in the acute sector said, oh, we don't want to do that. We're going to hack off the GPs. If we bounce back a referral, they may send it to another provider that they think will be more helpful and cooperative. And, therefore, we'll lose income and our organisation will lose out to our competitors. So that whole thinking about what's right for our population, what's the right level of intervention for this population, and how do we all collectively take responsibility for that is really important. And the trust clinicians was felt under pressure on the elective side to drive activity to cross-subsidise those parts of the system that need support inside the hospital. If we take all of that away and move to a cost recovery model and say, what does our population actually need, and then we'll pay what it costs, you take away some of those incentives. People stop talking about price and income and start talking about cost and optimal care pathways. So some of that sort of ACS thinking has really helped us. And now we're going through a process of structured collaboration with all of those providers and the voluntary sector and patients and all of our community providers together co-producing the right pathway for MSK in our patch. And we're hoping as a result we'll get better outcomes and better value for the Berkshire West pound.
And can I ask you, right at the very start of our conversation there, what you talked about in terms of patients and changing behaviour, changing lifestyle, I guess. You know, obviously every patient's different, every condition's different, but is there one thing that kind of tips the balance for many patients? I mean, why do they do this?
I think sometimes some of the things we think we've done the right thing by patients. The emphasis on sort of access and short wait times. I think sometimes some patients have felt propelled along and don't really like to say, you know, they find themselves, I've got a twinge in my knee week 1 and I'm sort of in a gown on a trolley in pre-op sort of a few weeks later. And I think giving people the space and the time, and there often isn't time in a primary care consultation, so creating a space for that is really important. We've had some really good help from our patients in things like our NHS 111 redesign, our headache pathway, our chronic fatigue redesign. It's been fantastic, and we have to unpack our own assumptions about what patients want, and sometimes where policy drives us, and go back to basics.
So is it actually time rather than money? Time spent explaining, and if you explain, you may save time and money later because you're not doing quite what you were doing before. That's quite extraordinary, isn't it? You're clearly slightly surprised by that, were you?
Yes.
Okay, well, maybe we'll pick that up in a minute. John Rouse is Chief Officer of Greater Manchester Health and Social Care Partnership. John.
Thanks very much. So we are also an accountable care system, but have this added ingredient of devolution, which means that everything we do in terms of decision making is linked to and rooted in local democracy. In terms of the way that we take and make decisions, and it is fully a partnership between the NHS, local government, the combined authority, and increasingly, and you heard from him this morning, from the Mayor of Greater Manchester as well. So we are doing all of the things that Amanda is doing. We're not doing some of them as well as Amanda is doing, but we are of a very similar menu, and it sounds like we can learn a lot on elective care from Cathy and her team. So I thought I'd take a different lens again, and actually this time just talk about some of the key enablers of successful transformation of health and care. And they are finance, workforce, digital and estates, just to give us a different perspective. So if we start with finance, we have created in our sub-governance a single finance committee, a finance executive group that has directors of finance from CCGs, from trusts and from local government treasurers who collectively take ownership, along with NHSI, for the financial performance of our whole system. And that means that obviously they're tracking and monitoring how we're doing against plan. There are conversations around control totals and are they fair and how we're going to meet them and so on. And by having that collective ownership, that sort of one for all for one mentality, last year we were able to deliver a 235 million surplus across commissioners and providers within our NHS. Now, things will get a lot tougher this year and probably tougher again next year, but I'm absolutely convinced that that collaborative model of the whole system owning each individual organisation's performance and without taking away accountability, providing a support and assurance framework around that was a big assist. Our second one is workforce. So here we've got a somewhat looser structure in that we've developed a workforce collaborative that has, again, the people you'd expect in terms of commissioners and providers, but also has our 4 universities. It also has Health Education England and Skills for Care as well. And they have developed together a single workforce strategy for Greater Manchester with 3 big priorities. The first is grow your own. So this is about developing our own workforce, really from school onwards, pulling through more apprentices and developing new pathways into the NHS and social care. The second is a more flexible workforce, making it easier for people to move within the system, including between health and care, and also particularly in integrated care services to take on new jobs like care coordinator, care navigator, regardless of the originating professional background. And then the third is a single approach, a coherent approach to hard-to-fill positions. And just to give you an example of that, we will see this year an increase of 11.5% in the number of nurses starting courses in Greater Manchester compared to a 6% reduction nationally. And that's because we've made it attractive for nurses to come and study and work here, and we see it as one piece across Greater Manchester with all the trusts and universities offering that course, working together. Very quickly on digital, very similar, single digital strategy, digital collaborative with all the key players working together, single chief digital officer, and then working with each of the localities and each of the organisations in terms of their contribution to that plan. And on estates, a single estates plan with a prioritised pipeline of capital projects, identified a financial strategy to fit with those projects, heavy emphasis on improving utilisation of space, linked to our acute services strategy, and then a very grown-up dialogue with government and the national bodies in terms of our need for public service capital for some but not all of the execution of that plan. So I use those as examples to show it is about frontline. Of course it is. It is about integrated models of care. It's about all the things that Amanda and Cathy described, but it's also about what's going on behind the scenes as well and making sure all those key enablers are supporting your frontline strategy.
And just on that point, Amanda raised right at the start there a very interesting question of people have got a certain statutory duty or duty, it's their job, it's their box to tick. I'm not using it in a pejorative sense. And then you're asking them to do something wider for the greater good. Sometimes some people will find it difficult to get their head around that.
Yes, but the way you can construct a different paradigm around that is to say by doing that thing for the greater good, you're going to find it easier to fulfill your accountabilities within your own organisation, because we are going to bring support to you to enable you to do so.
Matthew Swindells is NHS England's National Director, Operations and Information. How do you see it, Matthew?
Well, I think what you've heard here are 3 systems that are doing real change and are making a reality of what we were hoping for when we started down the STP and ACS journey, which was to create an environment for what's been described to me by one of the think tanks as the NHS's first ever bottom-up reorganisation. Create the space for you to make a system that works for you, putting patients at the centre, building it around place and around local communities, and expecting institutions to work in partnership rather than around institutions' own vested interest. And what we're trying to do is create a permissive regime where we can devolve regional and national resources. We can say, reinvent the payment model if you need to reinvent the payment model locally. We can say, you need to make your system balance and be of a high quality, and having one brilliant organisation and another failing organisation is not a great system. And it was really driven by the sort of conversation I had just over a year ago with one of the London Teaching Hospital chief executives, who, when I was discussing them with him, why he had such a high proportion of his population attending A&E. And he said, well, what you need to understand, Matthew, is that my chairman would not allow me to turn away those patients because that's how I make the profit on which I run my hospital. So I said to him, obviously, that if he needed help handling his chairman, I was prepared to have that conversation for him. But more seriously, that kind of perverse incentive that does run across the NHS of people being urged to do one thing and then being financially rewarded to do something else. And part of what we're trying to do here is to create an environment which says, no, get your heads together and work out how we make the system work as a whole. There's a fixed amount of money, there is a population that needs care. Now, how do you make that work? And some of the examples that we've been hearing, I think, are where systems are coming together and really starting to make that happen. And I think just listening to Cathy's story, Jack Wenberg, the inventor of the Population Health Atlas in the States, would probably be delighted to know that the study he did probably 25 years ago on if you consult patients over their need for urological surgery and really give them the information they need, a very high proportion of them choose not to have that surgery. Well, Cathy's just reinvented that study with orthopedics, and we've finally got a system which may be able to make best practice be adoptable across the NHS.
Excellent. I can see from the packed hall that there are, I assume, a lot of questions from the hall. We've got at least 2 people with microphones, I think, one each side. So who'd like to kick us off with some questions, some points, or some ideas? I think we're in the ideas business. Yes, there's a gentleman right in the middle there.
Thank you. David Clayton Smith. I'm chairman of East Sussex Healthcare Trust. We're running in a shadow form an ACS. And it's a very particular question. I was interested to hear all three aspects there. But one of the big challenges we have is in primary care and the shortage of GPs, particularly in some areas where we're facing perhaps 30% shortage of GPs. My question, I guess, is have any of you done any work on reimagining primary care so that we can cope with the accountable system with the shortage of GPs as it is at the moment?
Right, I think we've all got thoughts on that. Amanda, go ahead.
One of my jobs, I'm a GP. I'm a partner in a GP practice, and that what you're describing is reflected everywhere. And there's all sorts of things and schemes and programs going on to increase the number of GPs. But I fundamentally believe that we won't succeed in increasing retention and recruitment until we make it a job that people want to do and that is doable. So a lot of what we are doing is around supporting primary care so that GPs do the stuff that GPs are good at and are best at, and that we have other staff and other avenues available for the things that other people do just as well or better. So we have pharmacists in every practice doing not only medicines management stuff, but chronic disease management. We have a fairly well-developed out-of-hospital integrated urgent care system whereby we have acute primary care on offer where people can access through prescribing nurse practitioners, and we're training large numbers of prescribing nurse practitioners and paramedics who have a lot of acute experience and can train and adapt really quickly to an acute primary care environment. We are supporting primary care by investing in community services. There's been a huge decrease in the numbers of district nurses available and therapists available, but those people offload huge amounts of work that people are attending GPs with for lack of anywhere else to go. It's difficult everywhere. It's particularly difficult in coastal places, and you'll be aware of that. But we have to do something about the job. It's no good just importing more and more GPs and watching the ones we've got walk away. So it's about letting primary care transform itself into something we can sustain and deliver.
Matthew?
Yeah, just going back, I did a session with all the chief executives and accountable officers for the Kent, Surrey and Sussex area only about 2 months ago, and part of my presentation I put up a slide showing the density of GPs across the patch, because you have across those counties some very well GP'd areas and some areas of great GP shortage. And two things surprised me. One was that the accountable officers didn't know what GPing was like in the patch next to them, and every hospital chief executive was surprised to discover that there are areas of shortage of GPs. So I think part of what we're trying to do here is to create communication across the system whereby the solutions we find actually reflect the reality of what can be delivered. I think there's no question that we need to drive through with our attempt to recruit more GPs, but I'd also say that Amanda's point is absolutely right, that if I think it was a RCGP study said 27% of the people who turn up in a GP practice don't need to see a GP, but 25% of the people who turn up in an A&E really should have seen a GP. If we don't work as a system to make the whole of the shift, then the whole thing is blocked and you can't make the cascade. So what are the services that we at the NHS are offering to people who are coming to see a GP and never needed to see one? How do they need some sort of help and support, otherwise they wouldn't be coming to see a GP, but we could do it more efficiently than saying join the waits to get to see your local GP.
Cathy, Berkshire, similar kind of problem?
Very, very similar actually, and even the GPs that we manage to train we don't necessarily keep in Berkshire. It's an expensive place to live, so face exactly the same challenges. And I think Matthew's right to talk about the channel shift, and I often say to GPs when they're sitting in surgery, it's like trying to run outpatients and A&E side by side. We need to think about how we can stream that work to make the job more tolerable and doable, but also to help with getting patients seen in the right place. We've just launched our new 111 integrated urgent care service last Monday, and we're really hoping that we'll start to see some of the benefits in hours in general practice, and eventually that to be the mechanism for access to in-hours general practice.
And John, you mentioned raising your own and all sorts of things. Doing it with GPs is slightly more tricky, isn't it? obvious reasons.
But we're going to try in terms of increasing numbers. Just to add to what everybody else has said rather than repeating, one other ingredient that we've put in place is a GP Excellence Programme, which is across Greater Manchester, which is an expert hub which we've created in partnership with the RCGP and working with the individual local medical committees as well. And that's based on a model of peer support and peer review. So it's not just a resilience programme, although we will pick up practices that are really struggling. We start from the premise that everybody's got something to learn and contribute and run it as a network.
Can I speak, please?
No, neither.
Have you considered doing conversation clinics at GP surgeries and using members of the public and citizens to... Conversation clinic would be where a health champion type person, a conversation champion, might meet somebody next door in a cafe, and people get referred to the conversation clinic, and all those lonely people are just wanting to like talk to somebody accepting and normal, to tell them about their gas bills and their, and it would, I'm sure it would free up loads of GP time.
Okay, thank you.
Yeah. So we don't call it that, but we do have various aspects of that. We've done a lot of work in our central Blackpool most deprived area around community-orientated primary care, which has involved quite in-depth conversations with the community about what would benefit them, what would meet some of those needs, which aren't medical, but where people don't know where else to go. We have the citizens' advice working, offering support. We've got care coordinators and wellbeing support workers in our integrated neighbourhood teams. And so we're trying to pick up that very specific need, which actually people don't know where to go to meet it, and so they end up in general practice.
There's two people who want to come in there, but let's start with the gentleman over there. Maybe we can get a microphone to the two people there, and right next door to each other.
Thank you. I'm Robin Wiggs from Liverpool Heart and Chest Hospital. I'd just like to ask the panel what an accountable care system is accountable for and to whom it is accountable, and is that different in a devolved system like Manchester compared to leafy Berkshire?
John?
So yes, it is different. There is a higher level of delegation in the devolved system than there is in the accountable care systems at the moment. So overall within Greater Manchester, we have responsibility for over £6 billion of resource each year. That's split between my team, and I have certain delegated responsibilities from NHS England and some from Public Health England as well. And then also, obviously, the clinical commissioning groups, local government, the NHS Trust. And then we have a single governance structure which goes up to a strategic partnership board, which is chaired politically by the leader of Wigan Council on behalf of all the leaders. And that's where we get our, sort of ultimately our business done, plus through the sub-governance. What would be different? So we've got responsibility for about half of specialised commissioning budgets and modalities. And we've also got all our transformation funding for 4 years rolled up and delegated for us to decide how that's allocated, albeit that we've got to meet the 5-year forward view objectives. So that's 450 million over 4 years. Anyway, you add it all up and it comes to just over 6 billion a year.
Anybody else on that, Cathy? How accountable and to whom?
Yeah, so we're in the middle of signing our Memorandum of Understanding, actually, with NHS England. And so the organisations that are part of the ACS are signing up to be accountable to NHS England and NHSI for the system control total, which is broadly the CCG allocation plus transformation money, and to deliver the requirements of the 5-year forward view. So there is a formal line of accountability, and there is a formal assurance process that goes alongside that. So that's how that accountability will work. There are some things very, very similar to John. I mean, we've got all of our budget, we've got delegated responsibility for primary care and so on. For us, we're too small to take the responsibility for specialist commissioning. We would do that at an STP level because we're only about 500,000. We sit inside a larger STP. So it is horses for courses, but the principles are the same for everybody.
Matthew?
Yeah, I think, at the heart of that question is, I think, that this is not a statutory change. We haven't changed the law. We haven't created a new legal entity. So now, you could consider that to be a problem, or you could consider it to be an opportunity. The NHS does, as Gavin said earlier, reorganisations all of the time. This actually, to work, requires people's hearts and minds to come with it, because you can only run an accountable care system if the organisations within it choose to share some of their authority with the system as a whole, and NHS England and NHS Improvement choose to share some of their authority down into it. So it probably takes a bit longer to land something like this than just passing an act, but the chances of getting buy-in, I think, are higher in this way, and the possibility that we might actually create the behaviours as well as the structures at the same time is what I'm clinging on to allow me to sleep at night, because if everybody goes back into their cells and declares themselves as defending their organisations, this doesn't work.
I was going to say we're all in this together, but that kind of has gone out of fashion saying that, so I won't say that. I'll scrub that from the record. Gentleman there.
My name's Tim Benson from Our Outcomes. How will you measure success in terms of benefits to patients on a day-to-day basis?
I mean, with various outcome metrics, but particularly what we're wanting to focus on is clinical outcomes, also patient experience metrics. And part of our work really around co-design and some of the things I was talking about around the MSK is talking to patients about what's important to them. And as I say, that can be a surprising experience, and that would help us drive our impact and outcome measures, really. We want them to be part of that as well.
Amanda, what difference do patients actually see or feel, or do they not generally notice?
So what we're trying to do was the same as we were trying to do in separate organisations. We've got some very long-term objectives that are largely public health improvement related, around life expectancy, around chronic disease management, around outcomes. But in the short term, however unfashionable performance targets are, they are there for a reason. So we are measuring ourselves on delivering A&E performance, on referral to treatment times, on cancer pathway times, on transforming mental health services for patients. And these are, some see them as political or arbitrary measures, but these are real patient experience measured, related directly to outcomes. So it's really important that we don't get so caught up in designing a new system that we forget that if you've got a cancer, it's really important that you are diagnosed and treated very rapidly and appropriately, that if you go to A&E in an emergency, you are seen and sorted and treated in a timely manner. And so we are holding ourselves to account for the key performance measures in the same way that we were before. We're just doing it as a system rather than doing it by individual organisations.
Cathy?
Yeah, I can see a trick question when it comes over the hill, Tim. Tim has been inventing metrics for measuring patient experience since I was still in shorts. So I think that the answer you're getting are right, is that we're trying to measure a patient experience, and we have a lot of metrics in play. I would also say that as we develop our public consumer engagement with the NHS, the opportunity to have a much more granular feedback on what the consumer considers they have just received from the NHS, as opposed to the measures we put in place, is a step forward that we should be moving for, and is one of the reasons why we have to get the interaction between people and the NHS using technology to a level where we can understand it at a much more granular level than we can at the moment through our surveys.
Thank you. There's a gentleman there, and then the microphone to the lady at the front afterwards.
Richard Kemp from the Local Government Association. I heard a very interesting description from our last speaker that STPs were a bottom-up process. I must tell you that that's not something that we recognise. Chief executives of trusts getting together to provide a report which largely deals with NHS institutions doesn't seem to me to relate to a bottom-up approach where we would go from neighbourhood to community to area to district to council, and then the councils coming together through an aggregation of their joint strategic needs processes to actually find new ways with many partners well outside the health service. If we all lived in a decent house and had nice parks and places like that, we wouldn't have the call on the health service. So I think if you think STPs were bottom up, with the exception of Manchester, where the STP was a 3-year process which built on so much good practice, then I think you're badly wrong.
John, well, others will come in, but John, that was an interesting thing to pick up what Andy Burnham was saying this morning. I mean, the opportunities, and people will look to Manchester, Greater Manchester, as a leader in this.
Yeah, and in some ways, we are in that leadership cadre with the other accountable care systems, and to some extent, we are different, and we're defiantly different, by which I mean that we do see this as a joint partnership between local government, local democracy, and the NHS. And we're still fully part of the NHS, but we believe that we are building a bridge between the two that, in our view, should have been there from 1948 onwards and wasn't built into the system, and that is what we're trying to do. So it is a paradigm shift, and we're unashamed about saying that. And because of that, we are focused on things like school readiness and reducing homelessness and improving access to employment, and working with Chris Boardman, our new Walking and Cycling Commissioner, to change the way that we move around this city. And we're as passionate about that as we are about A&E targets, because we care about those as well. And so in terms of measures, you have to try and find this balance between the short term, which is really important, and the medium term, which you have to start to bleed together some wider public service ethos and objectives.
Anybody else?
Yeah, I mean, I would absolutely agree with the point about local government. And I think there is a bit of a risk that the STPs and the ACSs sound like the NHS going off on a little frolic of its own. I think what's happening in the areas where we're working the exemplars is there's a long history of that sort of integration and joint working. So in my patch, we have the Berkshire West 10, which is our CCGs, our NHS providers and local government working together as a cohort, and that been going on for about 2 years before we started thinking about accountable care systems. And what we're doing now is bringing those programmes together in a coherent way for all the reasons that John's described, really. So I would completely endorse what you're saying. It's essential.
Thank you. Lady at the front.
Hi, my name's Marsha. I've got both physical and mental health conditions, and about 15 physical conditions, and I take about 30 tablets a day. And I've started thinking about how I can control my own stuff, because every single tablet I take is more toxin in my body. You were talking about musculoskeletal. I've got fibromyalgia, which is very debilitating, and I'm using this table to sort of take some pain away from me. But I was watching something over the weekend, and it was about juicing diet, and how they went on a program for like a month, and it was amazing. And it's in Portugal, and it's £800 and something a week. But say for instance, the CCGs paid for me to go there for a month. There was people that their diabetes was reversed, they don't have fibromyalgia, everything like that. So is this accountable care thing about looking a bit also outside the box? Because imagine how much I won't have care in anymore. I may be away from that. How much is my medication cost a week? My patient transport to my hospital appointments and everything like that. So really, the CCGs need to sort of not think, they used to group by everything, didn't they? Block by and that. So it's my hope that you sort of, I know that the population plan, I do stuff with Greater Manchester, and I'm really proud of the stuff that we do and how far it's coming. But I hope that start seeing us as people, not just as money, and we will save long term.
Okay, there was a lot of issues there.
So, I mean, you're absolutely right. Unless we reduce demand on the system by helping and enabling people to take a role in and care of their own condition. So give people the tools they need to manage their own long-term conditions, whether that's education and information, whether that's the technology, whether that's access to personalised budgets so that their care plan for patients with complex conditions to be tailored. We are never going to reduce our dependence on relatively expensive in-hospital care. And so a lot of what moving towards a whole system approach enables us to do is look at individual patients or individual conditions and look at the best way to enable patients or groups of patients to take responsibility and become involved in managing their own care, looking after themselves and calling on us when they need it. Now, we haven't gone anywhere near packages in Portugal, but certainly that enablement of managing long-term conditions, as you describe, has huge benefits for a system. And this focus on the whole system and the whole system resource will enable us to do that.
Just one further, slightly wider point on that. I mean, what we've been discussing throughout the day is innovation and joined-up thinking within the NHS, and also local government and others. But in the end, the buck stops with government, doesn't it? You can take a lead in many of these things. And I'm not talking about any particular government, but it's up to government to suggest that actually whether children are ready for school age 5, as Andy Burnham suggested, I think he said almost a third of 5-year-olds were not ready. I mean, that has all sorts of issues attached to it, as do many of the things that we've been discussing today.
I think there's the role of government to say what shape of NHS do they want and how much they're prepared to spend on it, and to set sort of the core framework, what we call the mandate. The core framework of what they want is clear, and to an extent you can have an NHS for any amount of money a government chooses to spend on it. There's just things you don't get if you decide to spend less money on it. There's things you do get if you decide to spend more. But within that democratic boundaries, I think it's the role of the people in this room, the role of us, to deliver the best population health that we possibly can. And that undoubtedly involves being innovative about delivering care, but also making sure that a patient gets the opportunity to have a proper conversation with a GP about what the pros and cons of the medicines they're on versus not taking those medicines are, because that's a complex discussion that shouldn't be taken on the basis of a Channel 4 documentary or whatever, but should be taken on the basis of a adult-to-adult conversation between the person who's taking the medication and the person who's writing that prescription to get to the right answer for that individual, which may be different for you to somebody else with exactly the same conditions.
Just got a few moments left. Some other thoughts? We've had a couple sent in on Glyssa. Anybody else? Burning thoughts? Yes, gentleman here.
Hiya. I just wanted to. I was wondering. I think all of you would agree that self-care is an absolutely essential part of what needs to happen. And it's not just about reducing demand, it's just a better way of doing things, that you want people to feel that have a lot more control over their lives. But certainly from my perspective, having worked in self-care field for a long time from the third sector, is that most of the obstacles are not to do with people, they're to do with the professionals that are working with people and the perverse incentives within the system that make that thing. So what I want to know from the panel really is, how are you going to manage that transformation? And it would be an utter transformation towards a proper self-care model, changing the way the workforce works.
That's a good question.
So the first thing I would say is that it may not be right to start with the NHS. So I think the voluntary and community sector have got a massive role to play in this space, in facilitating cultural change within the statutory bodies, and also facilitating a different dialogue between the individual service user, carers, and the system. And just to give you one example of how we're doing that, we're backing a programme called Focus Care, which is run by a third sector organisation called the Shared Health Foundation, and that's embedding workers in GPs in our most deprived areas. We've got 22 of these workers at the moment, who can be drawn from a whole number of professional backgrounds, but they're picked on a value-based recruitment sort of process, because we recognise that they know how to have a different conversation and how to enable and facilitate people to help themselves and give them access to the types of resources that they need. And by embedding them within primary care, we can then train and develop professionals to to understand how that conversation looks and feels different and how it gets different outcomes.
Mm-hmm.
Yeah, I think it's a very important point. There's a study done a number of years ago putting a value on the self-care and supported care, the free care given within the economy, and the value was about £120 billion. So the value of the unpaid care service is about the same size as the NHS. And if you think of the amount of time we spend trying to make the NHS more efficient, use technology, use different ways of working, and then compare that to the almost no time at all we spend trying to make the care environment more effective, I think we're missing a big trick. So when you listen to us talking about new models of care, and when you listen to us talking about the technology strategy, we talk about self-care, we talk about carers, we talk about engaging the public, engaging the patient, engaging the person in their own wellness as key parts of that strategy, because frankly, I don't think we end up with an affordable health service in 10, 20 years' time if we don't manage to make the sort of transformation that you're talking about, and I don't think we know how to do it.
One of the things I wanted to pick up, and it links to that actually, is a lot of what you've all been talking about has been effectively soft skills about how to get people excited about it, how to get people to cooperate, how to get patients a little bit more time perhaps to explain things. That's this is a very much these are people with expertise and really hard skills. Is that a slightly difficult change to make, to start saying you just actually got to communicate better in some ways?
I think it's I think it's a really hard change. I think we've spent the best 10 or 15 years setting the NHS up to compete with itself, to operate on a trading basis, and we're basically saying that under the conditions that we're operating at the moment, the solutions we want are too complex for that model to operate. Therefore, the things that made you the best possible chief executive in the country 2 years ago, it's not the same exam paper anymore, and you need to learn a new set of skills. The things that we're expecting from our clinicians in terms of engaging a wider community, the challenge from local government, which I don't wholly accept, but I accept parts of it, is that we as the NHS have a box around us, local government has a box around us. If we don't work out how to make that a permeable membrane, then a lot of the things that need to happen won't happen, and we need to go on that journey together.
And you were in a way talking about soft skills, weren't you, with colleagues and others to try to do things better?
That's right, and the trick is to keep people well, and we are not going to do that as an NHS that devotes its time and energies to treating illness. The gentleman who talked about local government involvement, we absolutely cannot deliver this agenda without local government involvement if we don't focus on prevention, on reducing the ill health burden, on the self-care agenda, on social care and supporting carers and supporting home care services, and looking at the nursing care market and all of those things. If we just focus on clinical treatment of ill people, we're not going to deliver within the resources we've got. And some of the stuff that you're talking about doesn't need doctors, it doesn't need highly skilled nurse practitioners, it needs people who've got time, well-being support workers who've got time to sit and explain to people, sometimes for the 5th or 6th or 10th time, what each tablet's for, how to make sure they don't run out, have they had a flu jab, do they know what their treatment plan is for something they might have been referred to hospital for? All of those things take time and doesn't need me or other GPs to do it. It needs people at home with our patients and our community putting the time in to enable them to look after themselves better.
And I just wanted to give the final word, because we are out of time, to Cathy. Just in terms of your experience of it, it's been ACS has been quite surprising, has it? And exciting potential?
Yes, I mean, I think it's given those clinicians that intuitively want to work this way with their patients the sort of platform to do that. So the other example I would give is a work we've done on diabetes, where we've sort of completely transformed the model. People were trotting up to outpatients all the time, all of our diabetic population. Very few go anywhere near the hospital now. That's a community-based model. We've worked with primary care, with nurse specialists, with a consultant to support that team to do that, but also with Diabetes UK. And our patients have become completely empowered in their own condition. They access their own care plans, they know their results, they know what they mean, and they're empowered to sort of be in control of their own condition, really.
And
that's
happy
the
with
change
it.
we need. Yes, absolutely.
Cathy, Amanda, John, Matthew, thank you all very much. Thank you.
Okay.